So we'll start ticking with the first presentation. So the first one is Medicine 4, Terminator by Dr. Lal Sanghi. We will try to keep to the time, and we have been trying to look through all that you have presented. So there is usually a tendency to present all that you have studied about that particular case, but I think it's a part of your training that we would want you to learn how to focus on the main point that you are going to present to the case. So be conscious of the time and the number of slides you are going to do. So we'll start off with the first case, The Terminator by Dr. Lal Sanghi from Medicine Unit 4.
Good afternoon, everyone. I'm presenting a case of a 45-year-old gentleman from Sikkim. He came with complaints of fever, loss of appetite, and loss of weight for 3 months. He had low-grade fever, intermittent, not associated with fever or chills. He had excessive sweating at night, loss of appetite, and loss of weight of 25 kgs in the past 3 months. There was history of increased tiredness. Negative history, there was no localizing symptoms. In past history, there was no known comorbid illnesses, no history of previous surgery or hospitalization prior to current illness, no significant family history. Personal history, there was no history of smoking, alcohol or tobacco consumption, normal bladder and bowel movement. On examination, he was found to be tachycardic, hypotensive, and he also has pallor. Systemic examination, per abdominal examination was soft, non-tender, no free fluid. Liver was palpable 4 centimeters below costal margin. Liver span was 16 centimeters and spleen was palpable 8 centimeters below the costal margin. Other systemic examinations were normal. Differentials include infections like tuberculosis, leishmaniasis, brucellosis, histoplasmosis, malignancy like leukemia or lymphoma, paraneoplastic etiology like solid organ malignancy like hepatocellular carcinoma, renal cell carcinoma. On investigation, he was found to have pancytopenia. His LFT showed AG reversal and mildly elevated liver enzymes. Malarial parasites were nil. Stool routine parasites and stool local blood was negative. Urinalysis routine was normal. MT and expert TB PCR of the bone marrow shows no MTB, and blood culture and fungal culture showed no growth. Bone marrow aspirate showed this. Any guesses? Okay, this bone marrow picture showed numerous LD bodies, both in the intracellular space as well as extracellular space. Anti-RK13 was also sent, which was positive. He was treated with single-dose liposomal amphotericin B at 10 mg per kg. Disease clearance was achieved as fever subsided. There was decrease in the size of spleen, which became just palpable after 2 weeks. Bone marrow aspirate after 10 days showed parasitological clearance. A few details on the visceral leishmaniasis. Leishmaniasis is caused by protozoa leishmania. There is visceral and cutaneous leishmaniasis. It's transmitted by a bite of female sandfly. And visceral leishmaniasis is commonly caused by Leishmania donovani and Leishmania infantum. On the life cycle of this Leishmania, the promastigode is injected by the sandfly while taking the blood meal. It is phagocytosed by macrophages, and the promastigodes become amastigodes, which is then taken up by the sandfly again during the blood meal. Within the sandfly gut, these amastigodes get transformed back into the promastigode again, which is injected into another human's blood during a meal. Transmission is mainly by the sandfly vectors phlebotomus and lutzomia. Clinical manifestations, there can be asymptomatic infection. Otherwise, incubation period is usually 2 to 6 months. Patient may have malaise, fever, weight loss, splenomegaly with or without hepatomegaly. High parasite loads accumulate in the spleen, liver, and bone marrow, and they may cause severe anemia, hepatic dysfunction, or hemorrhagic complications. It may also cause mild renal impairment, which is reversible with effective treatment of visceral leishmaniasis. Prognosis is nearly always lethal without the treatment. With treatment also, fatality rates can be more than 10%. Lab findings, non-specific findings include anemia, neutropenia, eosinopenia, thrombocytopenia, elevated liver enzymes, and hypergammaglobulinemia. Definitive diagnosis is by demonstration of parasite by smear or culture in the tissue. NMN culture or molecular techniques like PCR and serologic tests using ELISA can also be done. Treatment case fatality rate of fully manifest Kala-Azar without treatment is more than 90%. There was a study done on single-dose liposomal amphotericin B for visceral leishmaniasis in India. This study compared the single-dose liposomal amphotericin B and conventional amphotericin B. Patients include 2 to 65 years of age with symptoms and signs of leishmaniasis, and if parasites were shown on microscopy of a splenic aspirate smear, intervention was 1 hour IV infusion of liposomal amphotericin B, and control was 15 alternate days, 6-hour infusion of amphotericin B deoxycholate. Outcome was measured by apparent cure or definitive cure. Apparent cure was assessed after 30 days with absence of fever, clinical improvement, and reduction in spleen size and splenic aspirate score of 0. Definitive cure was assessed after 6 months, being healthy with no signs or symptoms of relapse, and duration of follow-up was for 6 months. In response to treatment, apparent cure at day 30 was 100% for both control and intervention group, and definitive cure after 6 months was 95.7% in liposomal amphotericin B group and 96.3% for the control group. Adverse events, there was a reduced infusion-related fever or rigors in liposomal amphotericin B group, and hepatotoxicity and nephrotoxicity for both groups are minimal, like up to 1% only. And this result concluded that a single infusion of liposomal amphotericin B was not inferior to and was less expensive than conventional therapy with amphotericin B. Thank you.
Any questions? Yes, Dr. Anand.
Sikkim is not usually an endemic area, but one of the explanations could be immigrants from
Which are the endemic areas?
Bihar, Jharkhand, Uttar Pradesh. And
Going on to the western part of western part of West Bengal. So Sikkim is far north of that, right? So what does it indicate transmission? Did he have risk factors of a person who develops leishmaniasis? What are the risk factors of developing a patient? Whenever it is endemic, what habits would make people prone to developing leishmaniasis? The house they stay in, where they sleep, what would increase the proneness to a fact like that? Say they are non-bungalow houses, you sleep on the floor, and there is a sanitary patient, then so you treat the people, so the doors so should come in glass and sleeping on the floor. So some things that in this case, why did he develop leishmaniasis? Does it indicate transmission? Did he travel to an endemic?
there was no history of travel to endemic area, but one of the explanations could be immigrants from those Bihar areas to Sikkim. Endemic areas to Sikkim.
Yeah, I guess you need to have all the factors. The vector should be there, the patient should be, the host should be there to complete that. So Sikkim, that's what we are thinking is Sikkim, whether there's reported cases. Usually hills and all, you don't really find it. Usually it's in the plains. So not typically an endemic area, unless he had some history of travel. And as Dr. Anand said, it's understanding how the sandfly behaves and what height it can jump, and anything above that, usually they are protected, and people sleeping down are the risk factors for them. Any other questions? today the back seat is full. Okay.
How will you know even one dose of life so that
Yeah,
you know you're following? How long will you follow the patient? How will you follow?
We have documented paracytological clearance by repeating bone marrow after 10 days, and there was significant reduce in the size of the spleen. There is a chance of relapse for this visceral leishmaniasis up to 6 months, so we can ask the patient to review maybe up to 6 months.
Usually, bone marrow is not done, but patients are followed up, as you said, for long period and it is the spleen size. What spleen size? Reduction of spleen should happen. Follow what is that kind of spleen.
Okay. Sure. Thank you so much.